I think we all agree that was a bit of a heavy session before the break. I'm happy to see some smiling faces, which means that you've rejuvenated and are ready to move on to another highly serious topic, because actually it affects all of us. So I'm going to hand over very quickly to Walter, who lives down the road from me, actually, in also, you know, that is also my LinkedIn friend. And apart from anything else, is an eminent expert in this field. And he's going to chair the upcoming session on clinical diagnosis, racial bias in healthcare. So Walter, I leave you the floor.
Thank you for introducing me like this. But as a moderator, I am the least important person on this panel. Actually, the first question I asked when they invited me to moderate was, are there enough Black women on the panel? Second question, are there enough women on the panel? Because if not, I will not participate in the men-only panel. So, how did I end up in working on racism and health is, I'm a public health medical doctor working on tuberculosis, which is strongly linked to social determinants. And one of the stronger social determinants of health is actually social exclusion and racism. I've been working in Mozambique for years, being married to a Mozambican painter for almost 20 years. And by living, I don't have lived experience myself, but let's say second-hand lived experience by living with someone who came to Belgium and experienced racism, daily racism, police interaction that were not respectful. So in that way, it helped as well to push me into racism and health. Quite recently, in February 2022, yes, with some other health experts, we kind of co-founded a still unofficial platform of Belgian and Dutch health experts working on racism and health. Along as a member, Dr. Emma Kissy, Professor Joyce Brown, Niloufar Ashtiani, Bahar Godarzi, and I think yeah, exactly. So we know each other a little bit already. Probably most of you know or not know, but the Lancet came out with a whole issue on racism and health. It's a very good source of information. We managed to have a whole session approved on racism and health on the European in history. So things are kind of moving. There seems to be a momentum, and I hope we can keep that momentum alive. I'm going to introduce the panelists, and I hope, last check, Lael, can you hear us, please?
Yes, thanks so much.
Can we hear her?
Yes, turning up the volume.
You turn off the volume. Okay. So, Lael, you are the paper here says journalist, but you are actually also you have a PhD in virology, immunology, and translational medicine, I think. So should have been on the paper as well. It's very relevant. You know what you're talking about. And if I understand, recently there was a kind of a major life event that happened. Most of the people think I am talking about your book that came out recently, but you became a mom recently as well.
Yes,
So
that's right.
This is
my second baby.
okay. second one, oh, sorry. I just wanted to give a big shout out to all moms, all mothers, all grandmothers for their valuable work and unpaid care work that is very much appreciated.
Thank you.
So actually a few days ago or some few weeks ago, you wrote a book called Systemic, How Racism is Making Us Ill. I'm showing it here. Please all buy it. 20
Thank
copies.
you.
And would you like to introduce yourself a little bit? And yeah, would you like to introduce yourself?
Yeah, sure. Thank you so much. Yeah, so exactly. I also recently became a mom, so I guess the book is actually my second baby. But
Exactly.
yeah, my name is Lyall Liverpool. I'm a science journalist. I'm the author of Systemic, which is about the health harms of racism, looking at wider society, but also in healthcare and science. Systemic was published in the UK and US earlier this month, as Wouter just mentioned. But also I'm pleased to share that there will also be translations of the book in Dutch and German that will be available later this year. So I'm sure you'll be able to find that information. But before I became a journalist, I worked as a biomedical scientist, most recently at the University of Oxford in the UK. So that's where I completed my PhD in virology and immunology in 2019. And then since 2019, I've been working as a journalist, reporting on the latest developments in scientific research and policy. And I've been particularly interested in inequalities in science, health, and medicine. My writing has appeared in different publications, but for example, broadly read publications like The Guardian newspaper, but also science-focused magazines like Nature, New Scientist, and Wired. So I'm really happy to have the opportunity to join you virtually today. I am usually based in Berlin, but confusingly, right now I'm actually joining from London. But thanks for accommodating me virtually.
Yes, and I just learned that jij spreekt ook gewoon Nederlands. Dus zoals
Ja, ik kom uit
3/4
Den
van het
Haag.
panel. En
Ja, I'm
waarschijnlijk
from
ook
The Hague.
een beetje Duits. Like
Yeah,
Tanya.
I'm bisschen Deutsch. I'm a
So-
true European. So,
Very well, very
absolutely.
well. On to the next guest. Professor Alana Elber, proctor for University of Amsterdam. You're an anthropologist, social scientist. I love social science in medicine or in health. We need it. And her work, she works mostly on diversity and inequities in health and health research. So please go ahead. I'm going to give you the mic and introduce yourself a little bit.
Thank you so much, and also for the invitation. I'm really humbled to be here with amazing speakers and peers. So indeed, I'm a social scientist or an interdisciplinary social scientist working currently at an anthropology department within a program group called Health Ethics. Sorry, that's my old program group. My new program group is called Healthcare and the Body at the University of Amsterdam. Before that, I was at Maastricht University in the Department of Health, Ethics, and Society. So I do come from a public health and global health background, and did my PhD at the medical faculty at Maastricht. Now, my research, which spans by now 10 plus years, really focuses on the doing of diversity. So as we've heard today, there's very much a push. We have to be inclusive, we have to attend to diversity, and I think we all stand behind that. But one of the things that we've heard or seen shine through today also is that doing is essential. And in that doing, a lot of things, unfortunately, go, I wouldn't say wrong, but do not lead to the outcomes that we want. So when I think about doing diversity and inclusion in the European context, we heard it already at one of the opening speeches, that those conversations around this concept of race really kind of ended in many European contexts in the 1950s with the UNESCO statement on race. So then suddenly when we're supposed to do inclusion and diversity, where do we go back? Well, where we left off. And, this is a very problematic and ill-informed kind of conception of human diversity and population differences, which is all folded into that concept of race. So for today, I don't know if we're supposed to give like an outline now of what we want to say, but I'll keep it short. I guess we'll get to that in a moment. For today, I hope to be able to contribute to this event and to this specific panel through the case of racial bias in diagnostics by looking at, the causes of these different forms of bias. And as someone who theoretically kind of lives within science and technology studies, for those interesting as STS, science and technology studies meets critical race theory, I'm interested in the concept of race in medical knowledge production and the medical knowledge that we already have, but also in technology and hard technologies, actual technologies, but also soft technologies like public health information that is given to citizens, or even other types of technologies that are part of the healthcare system. We heard about Annie, our reanimation doll, but Annie in fact is a male because she used to be female, but that was problematic. So then of course she became just Annie, but without breasts, which indeed creates a bias in the knowledge that people have that we heard from our national coordinator today. So I'm interested in bias in knowledge, and I'm also interested in bias in providers, so provider bias. So on the one hand, like we have today, we've talked about intercultural care and the need for culturally appropriate care. But when I look at how that is done in practice, often what gets done is a lot of cultural stereotypes. Oh, you need to be intercultural. This is what Turkish women are like. This is what Surinamese women believe, right? So then we fall back on stereotypes. So in doing diversity, we have to tread very carefully. And when I was growing up, I used to always hear the direction is more important than speed. So I think that it's very important, as we all go, full force into diversity and inclusion, we really have to think about the direction and also the direction for different audiences, right? So if we all have a very good understanding of how problematic race is, let's talk about equity data and use race. If this audience does not know the history and how problematic race is, we have to be very careful using that terminology, right? So to really think about like what direction do we want to go in different parts of our healthcare system. And the last thing that I think is important that I wanted to address is also that we need not, have this kind of, I would call it French orientation, in the world where it's like Paris and the rest. It's Europe and the rest, but the rest actually has a lot to teach us. So when we look at racism and health in the European context, this is a minority problem, right? So the people who are disenfranchised are generally minorities, but the solutions to some of these problems are in areas where we are not minorities. But like in the same way that we have a norm of what the patient is, we also have norms about where knowledge comes from. Knowledge comes from America, knowledge comes from the rest of Europe, but for a lot of information about diagnostics or other types of medical knowledge, we have amazing research being done in Nigeria, in Ghana, in Ivory Coast, in Brazil, right, in South Africa, but we don't look there. So when we see issues with race adjustments in clinical algorithms, of course we can be like, oh, what to do, we don't know, we don't have any knowledge. You do not need to look far. Those same algorithms are used in Ghana, are used in Nigeria, and there's fabulous scientists who've done validation studies. So we can also think about, as we move forward, who do we see as knowledge authorities? And I would really encourage us to really look beyond, the biomedical American European focus as the institutions of good medical knowledge, and to really look at the rest of the world, because we are in need of the rest of the world to help us fix some of these issues.
You have only one mic. So I heard something about epistemology, knowledge. Who decides what is science and what is not science? So I think it's a very important fight we have to fight to recognize knowledge and science from non-Western, if to use that word, sources. The third guest, Tanya, you are a researcher at the National Discrimination and Racism Monitor, I think. And maybe one of the answers will come from you because you're also very much involved in community-based participatory research, which is another way of doing research. So please introduce yourself and go ahead. Yeah.
Can you hear me? Or? No.
Yes. Let's continue and
Okay. Hope now it's better. Thank you for the invitation. And yeah, to my person, originally I was born and grew up in Bulgaria on the Balkans of Europe. And I'm very much influenced by the colonial theory or what Maria Tudorova imagining the Balkans. And it influences my work till now because we can't decode the others of Europe, but we are the incompleted self. And I come from community organizing in the field of rights for queer people, or also HIV movement, HIV positive people. And that's how I combine my passion for community organizing with my passion for participatory action research. And now we are at the theme how would we like to approach racism in a sense of not reproducing epistemic injustice, which is already embedded in our institutions, or how to avoid following the white logic or what methods, as described by Bonilla Silva, is a very established Black scholar. And yeah, epistemological ethics are the focus of my work because usually researchers tend to look at the racism outside, which is the goal of our work, but also I like to also have a look at the racism in our institutions and to establish the approach called cultural humility, which means a commitment, lifelong commitment to reflect on power and privileges in our work. So that's it to my work. I think, Laia, because you started with introduction, and maybe I will give you the word to say something about your work, and if we have time, I can speak about the work at Germany, but I think it's important for her to have me.
I was gonna do exactly the same. So yes, go ahead, Lyle.
Yeah, sure. Thanks so much for the introductions as well. It's really interesting to hear your work. And yeah, I mean, I agree with a lot of what the panelists are saying already about the importance of addressing racism as it affects people's health. I think the focus of this panel is healthcare, so I'll stick to that. But I also just want to acknowledge that obviously health is something that starts way before the moment that you kind of enter a clinic or arrive at hospital. It's, what do we eat for breakfast in the morning? What kind of environment do we live in? Do we have clean air to breathe? Or what's our economic situation? All of these things have been shown to affect our health. And it's clear that these also contribute, that racism also contributes to inequalities in access to healthy living. So we already see a lot of inequality before people even reach healthcare. But then within healthcare, it's also clear that there are biases. Alana touched on this a bit, but there's also, systemic racism within medicine and healthcare. Something that I've looked at a lot in my work is this issue of race-based medicine. So for many years, there have been recommendations to adjust routine medical test results based on a patient's race. And it's in a way that is increasingly being seen as unevidenced, but also potentially harmful to patients. So just to give one example, and then I'll pass back to the rest of you. There have been recommendations to adjust lung function tests based on race in the US, but also in the UK and in other European countries. And these have been traced back to an assumption that was made by a physician and slaveholder in the US in the 1800s. His name was Samuel Cartwright, and he had this idea that Black people's lungs are weaker than white people's and that they therefore benefit from being enslaved. So obviously there was a specific historical context at that time. There was an incentive to label Black people as biologically different, inferior even, to justify oppression and slavery. But unfortunately, ideas like that, and including that one, have persisted in medical practice, way after slavery's been abolished. And actually, only last year, the European Respiratory Society and the American Thoracic Society, so these are bodies which publish recommendations for healthcare workers. Only last year in 2023, they changed their guidelines to remove the recommendation to adjust lung function tests based on race. And at the time, they published a joint statement in which they acknowledged that race is, of course, a social construct. It doesn't have a basis in biology. But obviously, I really welcome that change, but I think it's realizing that a lot of these problems are very current. It's important to know our history, but it's also important to know how racism continues to affect people till today. And maybe one more thing I'd just like to say is that a lot of my work has focused on the UK and the US. And I think actually European countries can learn a lot from these countries in terms of the collection of race and ethnicity disaggregated data. I understand, as someone living in Germany, there's a real reluctance in Germany to collect these kind of data because obviously there have been horrific things that have happened in Germany and in Europe in history, and we're worried about perpetuating that. But I think it is important if we can collect data in an ethical way, we can actually feel empowered to highlight inequalities in health and then also be able to do something about them. So I think it's really important that we also have access to data about health inequality. And I'm really happy to see that this is something that, for example, in the Netherlands where I grew up or in Germany, there's now more interest in kind of gathering that data. So yeah, I'm really excited to also hear more from the other panelists.
Thank you. And I know the next day, tomorrow, the topic will be heavily discussed during this event. So I heard race-based medicine, and there's an evolution towards what they call race-conscious medicine or research. Actually, what we do want to measure maybe is not so much race and ethnicity, but being exposed to racism, like being exposed to air pollution is a health risk. Being exposed to racism is a health risk. This brings us to how to do research, or actually how to register something like race and ethnicity and the dangers of doing that, the complexities, because you do not want to reproduce racism by registering something like race and ethnicity. And I think, Alana, I'll give the mic to you.
Yeah, so I think this was the Lancet publication, right? From race-based medicine to race-conscious medicine. So in summary, it says, well, let's do away with this biological conception of race and truly focus on the social determinants, including all kinds of environmental risk, economic, occupational, epigenetic determinants, right, that are the causes behind racial inequalities. And I think this is really important because I think that, within this kind of focus on epistemic justice within health research, I think one of the things that has to be tackled is the deafening silence around racism. And basically all of your book, Dr. Liverpool. So thank you for that. There's so much focus on people's lifestyle choices and whatnot and their culture that gets blamed for health inequalities, but so little on the political, societal, historical, economic, environmental ways in which racism shows up in health. But I also do think there is something missing, to be very honest, from the framework put forth in that Lancet article to focus on race conscious medicine. And this is something that I really get back to. I'd also be very interested to hear your opinions as a doctor. You know, there are population differences. And we also see that some, not but like very important parts of the bias that we see in medicine are because of a lack of inclusion. So if, you know, an example that got a lot of attention during COVID was, for instance, the finger oximeter, the little oxygen saturation meter. And that's not about race, it's about skin color. So it doesn't matter, you know, what your racial category is, but it's about skin color. But of course, skin color has been used to racialize people, right? And this is that nuance. So I do think that we can, you know, just saying race is a social construct, for me, this is, or saying we have to be race conscious, this isn't enough, because I do also think it's important to make sure that we attend to physical differences, not to overlook certain people. So of course, we want to make sure that, you know, we attend to skin color diversity and other forms of diversity. But I think the way to do that is to really talk about what the relevant thing is. So not to talk about race, but to talk about skin color diversity. So not to talk about race if it's going to be about hypertension, but to talk about the biomarkers behind that being higher in particular geographic areas and so forth, right? So I think that, yeah, the race conscious approach is really important, but from a clinical perspective, maybe we also need to talk about biology, but not in terms of race, but in terms of population difference. And I think that that will give us a more nuanced kind of a focus on, okay, if we're going to do inclusion, what exactly are we doing? And for instance, skin color is a big one in diagnostic technologies, be it the finger oximeter or the forehead thermometer, right? So the forehead thermometers have like a around 25% chance of missing fever in dark skin color. That is kind of essential to know, right? So these are, I think, the blind spots that we can focus on in addition to race as social construct, but also, you know, focusing on the materiality of human difference also has racism in what we do and don't focus on. So I think it's important to bring in biology, but in a nuanced way, if you will.
Go ahead.
I just want to ask, because we as a racism monitoring in Germany, we as a.
Is that not working?
You have to put it on. Is it on?
No, that one was,
That was the wrong one. Sorry about that. I just wanted to say, because we have to cover, you should imagine we have to cover all the forms of racism in Germany, like anti-Black, anti-Muslim, racism against people from Asian descent, racism against Sinti and Roma, anti-Semitism, and anti-Slavic racism. This is a challenging task, and we do it by approaching different methods, qualitative, quantitative, mixed source experiments, and also different methodological approaches. But what I want to say is, to give you an example, because we were discussing here, session is on bias, we use different contexts. We use the concept of racial knowledge. And basically, to give you an example of a study looking at a curriculum for medical students, and what we observed there is how racially marginalized groups are largely or systematically omitted from medical teaching materials. And this omission is evident on various levels. As you said, for example, people with dark skin types are seldom mentioned in the methodological or other teaching materials. And this locates groups with characteristic, for example, dark skin, outside of a common white norm, which was spoken about today. And another example is, for example, that racial social conditions are hardly ever addressed as a cause of diseases. For example, people with HIV, how these people are being brought in the conditions of being, but not having access to prevention or treatment and care, and the omission of the colonial history of medicine knowledge production is also omitted. But I want us to think about how this institutional racism, so I consider it as a disembodied form of institutional racism, how it is enacted in interpersonal interactions with healthcare users, because this becomes something which Patricia Field-Collins would describe as a controlling images. A doctor is seeing a Black woman, and this Black woman is offering HIV testing, even if it's not obligatory practice in Germany. Or having a Muslim woman denied having self-determined sexuality. We have a case when a woman asked for an STE test, and the doctor was like, "Oh, don't worry, it's not common in your culture." So you could see that that different races' knowledges are leading to different racial practices, and how institutional racism is reproduced in our day interactions, and how institutional and interpersonal racisms are linked. That's why I don't think that trainings are necessary, but not sufficient. We need to work on many levels, and it's not enough to be a good trained doctor when we in Germany have racial discrimination prescribed by laws concerning like refugees. By law, they have limited access to treatment and care, which means if I'm a dentist, a person is coming to me to be treated, I can't do anything. She's supposed to pay, or I can remove the teeth. It's the best case, but like prevention treatments or other treatments are not covered by the law. So basically, it shows also how health is also used as an instrument to govern or to regulate migration. And this is something which goes beyond interpersonal interactions and affects also if I was a doctor, it would affect also my communication with users, because even if I'm willing to deliver service, sometimes the German law says, okay, it's not covered. So this is a problem of many hospitals in Germany staying like they can't cover the cost of this, and which means people are underserved.
Absolutely. Lael, we see your hand. We have one person ahead of you in the queue though, sorry.
Sure, go ahead.
Mosiana, and then Lael, and then Mila.
Thank you so much, Jacqueline. I felt a bit of uncertainty and a bit of difficulty when not only Alana, but also the former speakers were talking about the blind spots, what we experience while addressing those institutional forms of injustice while doing this work, whether it will be in training, whether it will be in education, whether it will be in consulting position. The truth is, like while we're sitting here and online, I think most of us are willing to accept those new perspectives, are willing to accept those new ideas and like to be informed. But the truth is, at the same time, we also have to deal with the executive powers, whether it will be the healthcare, whether it be the police, whether it will be in other domains. And the truth also is that I think we are searching for solutions, how they can't ignore those blind spots anymore. And I really hope that today and tomorrow we can share those cases as well. So this is the first thing I want to address. The second thing is that I also felt a bit of uncertainty because I really appreciate and I respect the need and necessity to have a certain academic reality and evidence-based lines when it comes to discuss and to address what we experience in our work when it comes to exclusion, when it comes to racism, when it comes to discrimination. But also we have to deal with the factual reality of citizens who are dealing with this, and that we are their voices also as well. So I think when it comes to solutions, it also needs to go and figure out how these solutions from those communities, from those peoples, and from, like in the morning state, those patients are getting more central when we are building on solutions. That's the only thing I wanted to point it out. But while Elena was talking about this blind spot, I felt the necessity to share with you. So thank you so much.
Hi.
Yeah.
Oh, I didn't want to interrupt. Sorry, no, thanks so much, everyone, actually, for sharing. I was listening and reflecting. I think both Alana and Tanya also touched on this really nicely. And I was thinking that maybe a helpful way to frame this is to think about racism instead of race. I think there's a lot of conversations where we talk about race, where we could kind of replace that with racism. So like, for example, with the example of race-conscious medicine, thinking instead about, for example, anti-racist medicine. I've done a lot of research into this, but also, you know, I obviously have like my lived experience as a Black person. I grew up in the Netherlands. Now I live in Germany, and I've obviously engaged with healthcare in both places. Of course, there'll be different experiences in different countries. But yeah, I think recognizing also the systemic nature of the problem is helpful. I think you've touched a lot on how racism, you know, I think people working in healthcare really care about this issue, at least in my experience. I've interviewed a lot of medical students, doctors, healthcare workers for the book, and everyone, you know, it's a caring profession. People want to help people, but sometimes I think people don't feel equipped to do that. So just to I'll give a quick example and maybe like kind of solutions that we're already seeing. So as a teenager in the Netherlands, I experienced a skin condition, which I really struggled to get diagnosed. So I was experiencing itching and losing pigment in parts of my skin on my arms and face. My mother took me to see lots of different doctors in the Netherlands. We really struggled to get a diagnosis. Eventually, I moved to the UK, which is where I did my studies. And again, I was experiencing this condition. I went to lots of doctors and struggled to get diagnosed. And eventually, I was seen by a doctor who just happened to have darker skin similar to mine. And he was the one who said that, oh, what you have looks like a classic case of eczema or atopic dermatitis, which is a very common condition. So that experience kind of surprised me in how long it took to get diagnosed with such a common condition. And the doctor said to me that he thinks a lot of healthcare workers struggle to diagnose conditions on darker skin like mine, not because they don't want to do that, but because often they're not trained to do it. And so they find that more challenging. So since then, I've also interviewed other people who've had much worse experiences. There was one person in the UK who almost died from a life-threatening condition, again, because doctors failed to recognize that condition on her darker skin. But there are a lot of people who are working to make changes. There's been efforts to diversify medical education. And obviously I'm a scientist, so I just need to give some of the research I've done. Maybe some of the statistics are helpful. So, you know, research from the US was showing that 75% of the images in widely used medical textbooks showcase images on lighter skin. Just 5% show how conditions look on darker skin. I think Alana already touched on medical devices, pulse oximeters. There's research as far back as the 90s showing that pulse oximeters don't work well in dark skin. So this is knowledge that actually we've had for a long time. I think it's really important that we take action to tackle that. But there are even medical students. There's a medical student in London who developed a handbook showing clinical signs on Black and brown skin. And that's freely available online. So I think there's a lot out there that we can already do to kind of educate ourselves. This seems like something that's quite tangible that we can change. And then also talking about inclusion in research, for example, there's underrepresentation of people of African descent, for example, in medical studies and genetic studies and clinical trials, which I think can also be addressed, most importantly as a justice issue, because by participating in research, there's evidence that that benefits patients. And I think everyone should have the opportunity to participate. But also we learn from that, it improves the quality of the science. So I think there's a lot of areas in which we can tackle this, but framing that as an anti-racist approach where we want to be aware of how racism affects people's health. Living in a racist society is harmful in healthcare, but also in our daily lives. It causes stress, and that affects our bodies and our mental health as well. Being aware of that, when healthcare workers are aware of that, I think they can feel empowered to take care of diverse patients. And then also exactly having cultural competence, thinking about diversity of skin tones, which Alana touched on. So I think all of these things together will help us move towards a more anti-racist practice in medicine.
Wonderful.
Can I just respond to the question?
Yes.
Yeah, because before you do, I'm just going to say we still have a couple plus online. This has been a big conversation. So, Alana.
No, maybe just to respond quickly, because I really appreciate that question. These blind spots, you know, they're not necessarily blind, but maybe also very much silenced spots, right? So they're blind to some, but definitely not to those experiencing them. So there's silence. I myself have a theory about this called the triangle of denial, but it's about how, these spots are denied. But one of the things that's also very difficult is that there's also a lack of kind of legal infrastructure to reinforce things. So for instance, I analyzed the procedures that were taken, for instance, to introduce the forehead thermometer in some Dutch hospitals. And it is a complete silent spot. So they'll do research on like, is it wise to do this in the nursing ward, in the medium care and the intensive care? And then they'll say like, okay, we introduced the forehead thermometer not in the intensive care because the risk is too high, But nowhere in this report do you read anything about skin color. And it's, I think, also simply because it's not required. There's nothing to enforce, or there's no repercussion for just having these blind spots. And even when they come out, like there's also related to technology and skincare, there's a case in the Netherlands quite recently, just very briefly, online proctoring technology to see if the students was behind the computer. We do this sometimes when the students have home exams. This technology does not see brown and black faces very well. So a student was like accused of not plagiarizing, but like, cheating. And she took this to court. And even when there's cases, you see it's really difficult to get, kind of justice in these cases. So yeah, I think one of it is the lack of legal infrastructure that we have. Yeah, so thank you for bringing that up. Yeah.
Well, I'm hardly going to disagree. Let's put it that way. Mina. Oh my goodness, I'm losing my names now. So yeah, Marlies, and then a couple online, one online, and then Mina.
Thank you very much. Thank you. I really wanted to take this moment because we're trying at the end of the event to formulate policy recommendations. Just to mention some that we might forget at the end. And one of them is related to the use of alternative data sources and information. Thanks to what you were saying, I really want to highlight this. Not only using Anglo-Saxon sources. And 20 years ago, 1992, still in the university, and I happened also to be educated in Bulgaria. One of my professors told me when I came with a brilliant idea about research, I don't know what the research topic was, but I remember the answer. The answer was, if you have research question, first check if the Americans have addressed it, United States. And if they haven't, ask yourself if your question is not stupid. Okay, this was 1992. Now we are 2024, and I see that nothing has happened even on this side of the world, which in 1992 for us in Bulgaria, this was the civilized world, not any. Now, this really, I want to put it in our recommendations, and if the Commission also allow us to open our eyes towards research that comes, and you mentioned Brazil, but we miss the huge research outcomes that are coming from Latin America. Colombia in Latin America is probably the highest level of academic research that you can have, followed by Argentina. Nobody speaks about Colombia and Argentina here in this part of the world. Another thing is, we know what are the difficulties with the concept of race, and we know the lack of biological argument, but then again, it's something that is not addressed by the policy. And I call it the missing links. We have policy, which attends outcomes that we observe outside, but the policy rarely addresses who is the one who perpetuates racism. And those who are perpetuating racist acts, they do not care what is our or the scientific understanding of race. Those are people who discriminate based on skin color, mainly. So if we can leave this also in the recommendations, that we need to start addressing the politically uncomfortable topic, which is who is the pool of all those who perpetuate discriminatory acts. Right? and it's prominently missing. What we can use here as an input, and I will add to what you were discussing, the international recommendations. You might not have in all the countries the legislative grounds to address certain issues, but all of the European countries have signed the 9 core treaties, international treaties, and those are normatively binding in your countries. We don't get tired to repeat this, and there is your normative fundament to act against those acts that we are observing here. I would be careful, this also for our report, to expand and dilute the concept of racism to include people of not necessarily darker skin color, because then we are going to include all sorts of discrimination and hatred that we observe in Europe based on who is different, rather address the concept of fear from the different. And on data and statistics, yes, unfortunately, we need it. I hope you can help us to make better conceptualizations. And behind statistics, we can, of course, always hide the identities. Thank you so much, and thank you for allowing me so long time. Who follows?
Quickly, yeah. Hi, panelists. Thank you for the insightful conversation. I want to bring in the political perspective, yeah? So, we had a report that was released by the German parliament that said by 2035, Germany would have lost an equivalent of between 7 to 10 million people from the job market. So either through retirement, through loss of life, and simply people being old. So we're going to lose overall in the whole German market, people who are highly skilled, to a total of 7 million by 2035. That is nearly a decade away from now. And we have a problem that is ailing us and we need to change. And I'm speaking directly to decision makers here. The one thing that is happening is that what you're talking about having diversity is more like here in internal medical structures and how we engage within one another between us. But one thing that is missing is that we do not have inclusion in leadership and in medical administration. I don't know anybody in Europe and in Germany who is a racialized person who is at a senior position in medicine in Germany and in any other part of the EU. So the point is that through lack of these people in leadership position, it is harder to be able to bring in the conversation because medicine is a very elitist thing that if I'm coming in with a point to bring in and I do not have somebody who's backing me, how do I introduce this to legislation, even into internal medical practices? This is one thing that is missing. The second thing is that we have internalized racism in the upper echelons of decision making. I came to Germany with having finished medicine. I have already done my postgraduate. And then when I needed to register through the German body that governs students who are considered third country nationals, so not from the EU or the US, I was told that I needed to go to undergraduate school. I know right now a Nigerian man who has a PhD in dental surgery, who is not allowed to practice medicine in Germany because Berlin, who issues the state certificate to practice medicine in Berlin, is saying that we do not trust your level of medicine for us to trust you with our patients. Remember what I started with, we're gonna lose 7 million people, and that is our approximation. It could be more. So how do we bring in these people in from a more higher level sort of thinking? And I'm lost on how do we even start this conversation? This is an answer that I would like to have because they say that, yeah, but you see, we have our own kind of standards. The reason why we do not have Ghana, Ivory Coast, and all these other places having their research contribute into our research here is because we are like, yeah, but you know, they probably paid somebody money to graduate, so we cannot trust their research. I'm gonna say the truth, this is what they say. This is the problem that we have. So if you have any ideas how to start that conversation higher up, we'll be glad to hear.
Oh
Yeah.
my goodness. Sorry, go on, Wouter. We still have a person online that's desperate to say something, but go on, Wouter.
Just briefly, what we do is not only doing this and talking, we also include policymakers. Like on the session in Utrecht, we had the Vice Secretary General of the Ministry of Health, Abigail Norville, with us, and the European Commission anti-racism coordinator. Jacqueline and I have good contacts with the Ministry of Health in Belgium. We're trying to build coalitions, put it on the agenda, propose laws, propose changes, even on global level. And I recommend to follow this person. Her name is Dr. Tlaleng Mofokeng. She's the UN Special Rapporteur on the right to health. She's fierce, amazing. Follow her. And that's what we try to do on a policy level as well. I don't know, you want to add?
Maybe just very quickly, I mean, I think every context is different. I happen to be part, I'm so sorry, I was about to say, of a wonderful community of people working on this topic who are really miraculously found their positions, right, within these institutions, who are trying to change it from within. So I do think it's there, but I also think that there's a lack of infrastructure also in the scientific. So, you know, all the networking that happens through these European level things, those are really difficult for us, right? So we actually met at the Afro-Europeans conference, or that's why I first saw you. So I think it's also that, like, we are there, but how do we find each other, right? To do that work. I could say many, but I'll come back to it. Yeah.
What we did in Germany is they have established the so-called WINRA network, connecting all the researchers affected by different forms of racism, and they continuously also invite policymakers. So it's a continuous dialogue. And I know it also from the colleagues in the States, initiating also international networks can help to, for example, to shift money to, for example, for community-driven research when it comes to health issues. The States is the best example that it's possible to shift money to communities to do even their community-driven research, and also to target issues on data ownership and data justice. Yeah, who is the owner of the data is a very important question.
I can't even get the words out now. Niall, I see another hand going up. How is our online person doing?
I guess I'm the online person. Thank you so much for offering me the floor. I see that this discussion is very lively. I just wanted to put in two things as a public health specialist with a background in nursing, because we're talking about this racial bias in healthcare. And I did my master thesis actually on diversity and intersectionality in public health schools. And what we're seeing there is, from a structural perspective, these people are not prepared to teach for diversity, to teach for intersectionality, to include these very, very important concepts. And this is where the knowledge should be implemented, because we as students, when we're learning, when we're growing, we are having the knowledge. And when we're becoming professionals, this is where we can actually make a difference. And I think this might also be an issue in the medical context, in the field of medicine, that the knowledge isn't there, that the knowledge isn't promoted and not instilled in young students and young professionals that are growing up to be part and to actually make a change. And I think this is a very, very crucial part where we have to step up. This would be my very short contribution. I'm not sure how it is with the data in medicine, if there are any surveys or any, how is diversity actually acknowledged, represented in the field of medicine all across Europe. But from the public health perspective, from the people doing the policies, there we can really see that if people are not intrinsically motivated, if they are not interested on a personal level, then they can totally avoid all topics of diversity and inclusion and intersectionality throughout their entire academic career, which can't be happening. It's the year 2024, yeah? So we have to make a change there.
We're all applauding you, Emma.
Thank you so much.
We're all applauding you. Leah, thank you, Emma.
Yeah, I'm really glad. Thanks, Emma, for that point. I think it's so important. I mean, this is a big reason that I wrote this book, and I wanted to kind of create a resource for people, for general public as well, to learn about these things, but also for people working in public health and in medicine. I think this issue of education is really important in medicine too. I've been doing a lot of work with medical students because I really think it's the future of our health systems. And you know, people care about this. Like there was a survey of international users of a medical teaching platform. So these are medical professionals around the world, and only 5% said that they felt really confident diagnosing, you know, health conditions across diverse skin tones. So that's really low if you think about it. That's a, you know, skin color like varies all around the world, but this represents humanity. In Europe, we have really diverse populations, and it's so important that people, doctors, healthcare workers, but also those who are training, medical students, people working in public health, that we have that awareness of diversity and we feel educated about these things. So I think having those resources and amplifying the ones that already exist, there's a lot of work on this in the US, but also in Europe, developing more diverse teaching materials for medical schools. I also really think those of us who work in kind of medical research or even biomedical science should remember our colleagues in the social sciences, because actually the social sciences are far ahead of us when it comes to considering racism and social determinants of health. There's so much brilliant work going back, you know, years looking at this, and people, many brilliant people and organizations have been kind of sounding the alarm on this issue for a long time. So I think that we have that material there, we can educate ourselves. And yeah, it's about bringing it to attention of important people, which I think one of the earlier questions touched upon. But I think the fact that we're having this conference already, it's really important. I wouldn't underestimate it. Just having prominent organizations like the Lancet Medical Journal, the World Health Organization, recognizing that racism is a public health crisis, that is huge. And that's something that's just happened in the last few years. So there has been a lot of progress. And I think we can then now do more in the EU, especially in terms of prioritizing the issue, really naming racism as a public health threat. And prioritizing funding for research on racism and health in the EU. I've talked to researchers, for example, in Sweden, who was telling me that she actually doesn't mention racism when she's applying for research grants, because she worries that by mentioning racism, she will not get funded. And she is a researcher who studies racism and healthcare in Sweden. And I think this is a common experience for people who work in this field in the EU. So we can really do better to prioritize that work and show that it's important by having events like the one that we're having today, for example.
Leave it up to you to finish.
Thanks. Yeah, it's time to finish, I think.
This segment, yeah.
Yeah, this segment. So first of all, Lyle, thank you for participating online. Hope to see you soon again. I'm reading your book, very enthusiastic about it, and keep doing what you do.
Thank you so much.
Bye-bye. The other panelists, Alana, Tanya, thank you very much for participating, for being here. And I'll give the mic back to both.
Thank you, everybody. Thank you, Emma. Hang on. Okay.
Wow.
I know we ran out of time. I'm so sorry, Joel, because you've been so diligent all day. And you know, so quiet. I feel really bad. Am I allowed to give? No, I have to move on. I am? Okay, keep it
Sure,
short.
yeah.
Keep it short.
Okay, I wanted to raise a point, a different aspect. It's about double moral standards. If we look at combating traumas in racism, there's a lot of research done on trauma experience of people who being exposed to all kinds of everyday whatever. So why are those researches not applied on Black people when they experience traumas? I mean, there are a lot of medical studies already done, even for the white population. But when it comes to Black people or people of color, it's not applied to. So that's also something we need to address. There is a lot of knowledge already out there, but it's not being applied.
Okay, so actually that I'm really pleased that my boss gave me permission to make you say that, because it's an excellent segue into our gap analysis. I mean, and they're putting it up now, because coming from the world of obesity, we actually face exactly the same problem. And in, if you like, research terms, it's about being able to target or identify a subpopulation. And what tends to happen with people with obesity, which I can just, change out the wording here, is that you have a general population, and they could actually be asking relevant questions within the cohort, and they only actually ask for BMI, which is not about obesity. And we see that as well when I've been working on different projects, for EU projects. I've been asking, within obesity world, can we actually track what's going on for different people of African descent? On one project, we were given people in South Asia actually living in South Asia, and told that that would be the same as if they were living in Europe. And that's the best that we could do. So it is something, and I think, are we ready now? Yeah, so it is something which I think acts as a great segue, which is our last segment of today, and some homework, because we're going to be giving you a poster when you come in tomorrow. We're actually, you remember I said at the beginning of the day that we needed to think towards solutions. Well, Bridget has been taking amazing notes all the way through on a Miro board, which it will miraculously populate. So all the points that we've been thinking about throughout today, can you lower it down a bit, please?
I don't know where to start.
No, so we can see the title at the top. Basically what we've been thinking about in the different sessions. I just need to see the title.
Yes.
Yeah, so what we've been seeing, so the national and European policy, I should actually just log in then because I can't, okay. Then we moved on to mental health, then we moved on to bias in systems, and then racial bias in healthcare. So that's actually what you've been thinking about, or certainly what was discussed in the panels. Now, the gist of it is that there is more that can be done. We already identified in the speakers what can be, what are the different issues. As far as audience input, we also need to work out from you what is missing. So we'd actually like to get that ball rolling already now, before you go off, an aperitif before dinner. At your various locations, to start thinking about when we come up to the new strategy, because that's what we're here to think about really. When we come to the new strategy, given all of the discussions and also your own experiences, what do we consider, which areas do we think are already missing? I see a hand, great.
So thank you. My name is Ashley Strugel. I work for Sanofi. It's actually a pharma company. I'm not evil, so I'm good. And I've been recently assigned to lead the European activities within the company to increase diversity and inclusion in our clinical trials. We are producing, as a pharmaceutical company, we are doing a lot of research, and our trials are not diverse. A lot has been done already in the US because there are regulations in place. In Europe, it's not there. So Sanofi is taking a step forward, and that's why I'm here, and we are trying to do our best. We've been given as individuals the chance to change things, and we are trying to do it. But it would extremely help if there would be also some regulations in Europe to support the work that we do internally and externally. You know, that's, and I don't see here, I mean, given the amount of research that's been done by the pharmaceutical industry, I would expect that one of the stakeholders in this meeting would be the European Medicines Agency, or perhaps some of the authorities doing the HTA assessments, because they are not asking for diversity and inclusion, and that's so necessary, you know.
I think it's, yeah. Okay, so two things, and I want to see some more hands, but yep, I said, wow. No, I think a lot of you now. I was like, oh my goodness. Okay, so two things. You might also want to think about FPIA and IHI, so the Innovative Health Initiative. I was actually the person that wrote the patient engagement guidelines.
You were part of it.
I wrote it. So the first guideline.
Okay, so we know.
Back to me. So, but you can actually go back. That's about patient engagement. There was also a project called Paradigm, which I was asked to participate in, and I said no, because actually there were literally, as I think Alana was saying, it was literally, it was about clinical trials and patients in clinical trials. And to put it bluntly, at the time, I was the only Black person that was, that they could find. I said no, so because I wasn't comfortable with how that was run. So there is absolutely plenty of room for that. But I would say there's an opportunity certainly to have that better discussed within FPIA. So for those of you who don't know FPIA, it's the trade association for biopharmaceutical companies, so pharma industry for Europe, based in Brussels.
But are there discussions in there? Because I was talking to my colleague in regulators and she said, yeah, it's kind of quiet.
Yeah,
I do not hear anything about diversity and inclusion.
Yeah, it's quiet. Come talk to me in the break. It's quiet, but there are a few workarounds.
Yeah.
For the new IHI. Okay, okay. 1, 2.
Yeah.
Alana? Oh, sorry.
Okay.
I'm so sorry. I didn't see you. Okay,
Yeah.
yes.
Okay, I'll keep it very brief. I think on there also, we really need to talk about language and how quickly language takes on new meanings. So I heard the word racialized several times today, but I see the relics of like the otherization, because in that word, it's almost like white people are not racialized. Like the whole concept of race was to invent whiteness. So if there's anyone who's racialized, it's whiteness that is racialized. So I think like language is really important. So even using the word racialized, saying racialized people, this tends to mean like everyone's racialized except for white people, making white people again the norm, the standard, And of course, none of us intend that. I've used this word myself, but as it becomes used by other people, it takes on new meaning. So also really to pay critical attention to the type of words we use and how others might use them or how they might take on meaning in other contexts.
Absolutely. I think when we started the whole DISCO network, there was a big discussion on language and taxonomy. It keeps coming back.
Yeah.
So, okay, I'm going to go very quickly here. Oh, sorry.
Yeah.
I see. Oh my goodness.
My question very much relates.
Okay.
My name is Erwan Geeman. I'm part of the IGA team. So my question is actually a very practical one, and it links to many things that you were just mentioning now about language, about solutions, about not going with the flow like that fish and having that difficult conversation. So my question is, what could these conversations look like in boardrooms of medical schools, for example? And I mean, which words are you using? Also not to instigate, kind of the anti-woke movement. So how could I, as a white man, in a very constructive way? So the question is to anyone in the room, do you know of any resources of, maybe role playing? So what could these conversations actually look like? How can I do it? And how can I do it better? How can I practice to have conversations, for example, to have more diversity in positions of power?
Yeah. Okay. So I need to not answer that one because I've got plenty of examples, but this is not the Jacqueline show. So I'm going to, so I'm going to ask who with us has examples to put us in the right direction.
Answer it, but
Yeah.
we would like.
Okay, so
us to
Marciana.
discuss it.
Yeah, so who should I give the mic to?
But afterwards, I will answer. I will give some.
Okay, and so this gentleman, he came to at the beginning of the day, and then we're going to go over to Modi.
Okay.
Okay.
Thank you very much, Dita Mulumba, for the Foundation Mulumba International for People of African Descent. And I have the quick one. I need someone in the audience to help me understand Windrush syndrome, and bad mental health in Europe. I'm a little bit lost. I'm trying to understand if there is a link. I've many other questions. That one is the most important for me. Today or tomorrow, if someone can help, that can be something very interesting for me.
So for the difference between Windrush,
yeah.
So
if there is a link, if yeah. I've been last week in the UK. I saw there is some kind of compensation for the Windrush. So
Yes.
I was asking myself, okay, what is the link of what is happening in the UK? And we are here in Europe. So is that something that we can do to go ahead with what we are facing here in Europe? Because there are many issues that mental health.
yeah, except that Windrush, and I'm going to move on slightly here, but just for those of you who haven't been following the whole saga in the UK on Windrush, Windrush was the first, well, the most famous ship with invited migrants from the Caribbean. So from just after the Second World War. And basically a lot of that generation and the next 20 years, I think counts as the Windrush generation, never regularized their paperwork in the UK. So what we saw was that a lot of people who never got a passport suddenly were being shipped out the country to places, particularly in the Caribbean, where they had no ties. So it was almost like the Conservative government saying, go to Rwanda. That was literally what some people were facing.
Rwanda bill.
Yeah, and there have been a lot of mental health beyond issues related to that. But actually the reason that everyone ended up getting compensation wasn't necessarily down to their mental health, which would be the conversation here today. It was down to just the illegalities of it, and not actually going through the correct process and the slows and all the rest of it. So the mental health was actually just a fallout of it. In our case here for this conversation, what I thought you were going to say, because we spoke this morning, so I'll say it for you so we can put it in the remit of the conversation, was the importance of perinatal screening or natal screening for rare diseases systemically like sickle cell. And that is something that we've missed, which ties into what you were saying about basically clinical trials. That's what I thought you were going to say, and I'm going to grab the microphone. It's here. So where was I? At the back of the room, Nila. Oh, Modi. Yeah, thank you. Yeah.
Thank you, Mila. Thank you for the meeting. Very interesting. It's like a gift since our last discussion. 2 points about, I'm going to start with the last one with the cycle set. Thank you, Jacqueline, for raising it, because there's, of course, all those impediments linked to the diagnosis and so on, but there's the case of sickle cell, where it's predominantly present in the African descent community, whereas not only, and we're in Europe, and today
we have to acknowledge and raise awareness that we are together. They're mixed couples that are coming together. And when it comes with all couples made of people from the Mediterranean area, there's a higher factor of having cycle diseases in those families. Speaking from a lived family experience, you don't know it until you know it in the end. And that's also one of the really big issue where policymaker and true inclusive legislation is needed. When it comes to research, traditionally, researchers from the global south, African researchers have always been sidelined when it comes to seniority or valuing their research and the work they do, whether it's within the pairs of the profession, whether it's the pharmaceutical industries. We've seen the case with the COVID, and you've all followed the Artemisia, Walala, and the research that are based and done in the South are always considered as second best, if I may express myself that way. And that's also something where we address the pharmaceutical when they claim to be more diverse. To which point do you really want to be more diverse? Is it being diverse into including those researchers within your structure, or making states and policymakers, giving them the means to really come up with a solid research, better research condition for solutions? This is, the diversity is not only by including us, but it's also by enabling us to be next to, together in that same area. And that falls onto the, what do you do voluntarily? What conversation do you want to have? At this point, I always lose patience, is that it's not about a conversation that we need for inclusion. It's about a voluntarily act of willing to include the right person, not the perfect, because there's also this discourse when we are in the elite, and I consider that all of us Black people here are the elite. When it comes to include us, do we fit into the elite standards, or we're not elite enough? There's this little imperfection. We are asked to be square perfect. What does that mean? Nothing is square in the world. Everything is round. So we become perfectible. And that's how you can do your inclusion. Test and move on. Because in a job, somebody not performing, you fire them. So, but before firing them, you had to include them. You don't know until when. So for me, I don't think it's a conversation. It's a decision that you make to include one person, two person, or the other, whether Black or not, but in diversity. Like we did, like we've always asked for women, it's the same voluntary act of including and changing. And their policymaker have to be more more stringy, more on the faith on putting laws and controlling. Because in the end, if you don't do it, and we know inclusion on the work market is just some words. I'm a militant, so it's just a word. There's nothing that can, I mean, constrain, put a fine on someone who's not inclusive enough.
Okay.
Where the pocket is not taken, punished, there's no movement. We know it. And for the base to really struggle to it. Sorry for being long.
Okay. I think you've actually hit the nail on the head. I'm going to, because we're coming up to time, but I see some more hands. So I'm going to say, try and keep it solution orientated, and don't forget we're giving you homework. ladies.
I'm good. Unless you pass the moment.
Oh, sorry, we have two more over here. And while the mic's coming around, I'll say it as well. We're hearing a repeated theme of basically get this in writing, that there needs to be infrastructure so that, well, I did say it, that there can be sanctions, because if something is not actually demanded or made compulsory, it's not going to happen from a number of different stakeholder groups. So I think that's a clear directive as part of what we're dealing with. Who has the microphone? Great.
Okay, I want to speed run 2 points very quickly, and I want to address the issue of the word race. It's a whole conversation we're having in Germany, and I'm sure that's what you want to talk about. We have people who are saying they wanted to remove the word race from the German constitution, and we have another group of people who say the word should stay inside. I hate the word persons with migration background because I get to argue with people from Poland that they are persons with migration backgrounds. Of course, technically, yeah, but underlying dynamics don't count. So that's one thing that I just wanted to mention with that. And the closest thing that we have heard to having the word racism in the context of the English language, in the German language, is the word rassifizierte, like we are racialized, we are othered. And so now most people who are publishing articles, be it law students and judges, they're trying to use this word in this context. And so the second part of why it would be difficult to standardize this is because we don't even have a definition of what racism is in the German law. So we tend to work with assumptions. That's just what I wanted to clear first. I'm sure the commission will have a nice time dealing with creating a law that works for all the states. But anyways, I feel like we need to include transgender healthcare research on everything that we do. In Germany, we spend €500 billion on, I think it's last year we allocated it to healthcare, but none of that money was allocated to transgender healthcare research. And I think it needs to happen now because I am seeing the weaponization of academics. A couple of weeks ago, the 128 doctors meeting, blah, 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 issued a statement saying puberty blockers should not be issued to kids. It should be issued only in study context. 3 days later, the British see that, and before Rishi Sunak calls for a new election, the British ban the issuing of puberty blockers for the next 3 months.
Yeah.
So that's what I feel like. If we can be able to have a bit of enough research to beat the right-wing extremists inside medical systems, maybe we can beat them to the punch to say, yeah, but there is already existing research that is being backed up by 40 years of issuing these medications. And that's one aspect for kids. But also what we were talking about today, in Germany, we have no standardized system that focuses on mental health, but not in the sense of paying for mental health, but specialized mental health care. So we are having speaking in German, we're having a lack of people who are psychologists or psychotherapists. There is a shortage of that right now. But then on top of that, for you to find somebody who's culturally competent, good luck. So that's one thing. If you can have 1% of €500 billion, that money could go so far in changing so many lives. So just what I feel like should be added there.
I mean, 100%. I literally could be substituting the word for obesity right there. So I think that what's coming through is, as was mentioned, to move forward, health workforce actually needs to be sensitized. And as was in one of the panels, sorry, it's telling me to take a pill because I know, sorry. So to be sensitized and actually have, what was it? Race conscious medicine and also race conscious health workforce, I would say, which is actually a big issue now within European policy. So actually we're on the right track there. And again, the points about research. So we're about 2/3 through the current research agenda. So I'm looking at those who were talking about clinical trials and saying, you know, there's a lot to be discussed amongst that. Oh my goodness. Okay, wait. You were waiting, and then Marciana has the mic, so. Okay, so
Just one sentence. To my opinion, today I've get a lot of contribution and think 90% of the contribution is about consciousness. What is our consciousness when it comes to esteem? And I think only 10% of what I've heard today is about what to deal and how to deal with the current powers. Just wants to mention it.
I will take it just because I'm next to you.
it's coming to you. It's going.
I'm okay.
Just one aspect that also we are forgetting. Life cycles. We didn't have in the conversation any focus on elderly people and old children and those who do not get voices. And also in the context of the development of new AI technologies, which are in a way excluding those populations. Yeah, so.
Excellent.
Yes.
Thank you so much.
Okay.
Thank you.
Thank you. A small sentence on power, on European policy. It's like what you spoke about, Jacqueline. We see that there is a to-do on anti-discrimination action plans for the European countries, but is there also an obligation for the countries to have a national coordinator, or even better, a national rapporteur who has more mandate than not to belittle our coordinator, but I think on a higher level, someone who can actually what do you call it? Not penalize the
build sanctions.
Sanction the government if they do not do what they need to do. And I think if we're talking about racism and health, that would be something, one of the directives that we would need to fill in the gap.
Absolutely. In policy speak, that would take us into the European semester. So, which is basically it was revamped post-COVID when we looked at health system resilience. So basically it's how well, against which criteria is a health system actually performing. So that could, I would say, be quite easy from a policy perspective to say, okay, we want to see that in the health chapter, that because we're mainstreaming race discrimination, we want to see to what extent do these legislative packages have teeth at national level. And the good thing about the European semester, and I'm sure there are others, but from a health perspective, it's a really easy one. Because when countries or EU member states don't perform and don't deliver on what they're supposed to, they can get fines, they can use all kinds of stuff. It's really good.
Brought to court, whatever.
Yeah,
Install those bodies.
Get punished. So, but it's the principle. I'm coming to you and I see your head nodding away. So basically, it's a way of saying that there are existing instruments where we don't have to reinvent the wheel in order to hit the desired result. Yeah. Okay, so I'm coming to the end. Yeah. I'm coming to the end, both physically and figuratively, because, gosh, you guys are still awake at night. Yeah. Okay.
Thank you. I was asked to share this part. Yeah, sorry, Sabine Jones, I'm working on neurodiversity. I was working for a government, a European government before the children's rights. Just to summarize, we have been speaking about research to make better research, to also increase policies, to increase law, to increase punishment also towards those who don't want to follow the rules. when we want to fight against something, we have to know what is what we have in front of us. And also there is the culture of the population. Why the population has this consideration. We talked about elections, of course, and if the example that I was speaking to someone here is France. France is the first to have surprised everybody in Europe. And at the same time, it's the point that I wanted to point out because it's really important to understand the culture. This country, when you make some survey statistics about what is the personality, the preferred personality of the population, the four persons who arrive first are Black people. So we have really to also do some research and to study the effect on the population, what's going on and why. Because otherwise we will miss. We can punish, we can make laws, for sure. We can force, but we have to study, to keep in mind also to study and to look for also besides other solutions. And the best way is to understand all kinds of people who are interfering in this situation. It's really important, I think. And also because speaking about the election, we know what would be the result in France, for example. Even if they close, there are many means to put a person into a condition where he has no other alternative than to follow what he said. If they close the borders for immigration, then they have to face that, okay, it was your problem, but then you have to help the integration, because now you don't have this problem anymore, but you have also some people who are suffering. And you said you will work on this integration. So now do it. It's, yeah.
Okay, thank you. So, oh, yeah. Last one. No, I'm looking at you. Oh, sorry, did I miss somebody on the other side? No, I'm saying, it's 7 past.
So very fast, in terms of solution-driven data. Data is an important point. Collecting data has been collected. European Union if you look at European Union countries, every country has its own system. Within a country, you have different systems as well. If we need to analyze this at European level and look into prevalence of disease, I think Vanessa was doing some quick research and she couldn't find this information on the internet. And you mentioned something like this in your presentation. I think that could be one of the reasons. We need to put this data together. There need to be some funding and some interest, because otherwise we will start from zero and there is data already there that we can learn from.
Yes, there is. And that is an amazing segue into what's going to happen tomorrow. The reason I say it's an amazing segue, the reason I say it's an amazing segue is because, yes, we're going to give you homework to think whatever else is missing. And I do believe Thomas is going to bring in some nice post-its so that you can keep adding the elements that you think are missing, because we're going to be working so hard just before we all leave for the summer break to make sure that we have a decent report. Now, the reason I said good segue is because tomorrow we will actually spend the vast majority of the day on data. And actually, I find that prospect extremely exciting. So I don't think data, whatever. But actually, we've just come through at European level, the European health data space. We've just come through it. It has to be implemented across EU member states, supposedly by 2025. In Belgium, we have equality data that can be used for healthcare, looking at the intersectionality, including for race discrimination. I don't see her here today, but I know Unia is sending a couple of people tomorrow and actually sat on that working group. So please come ask questions. We can make introductions. There's also the issue with the usual legalities issue about data privacy. I fully expect a really robust conversation on that one as well. So I think for today, you can breathe because actually we've all done really, really well. And I think it's we've come through a massive journey, which has been up and down, up and down. We've done lots of breathing, thanks to Ocean as well. I just thought that was fantastic. We've actually talked about some really big elephants in the room, from start to finish. But actually, we're starting to see consensus already. There are already some recurring themes coming through, which of course is infrastructure, which of course is health professionals. I think that's just, I left my old job, I'm sorry. I'm no longer representing health professionals. But you know what? It's something that we can actually know that we have to bring in. The research is already here, which is a good thing. So I would say have a wonderful evening. We will see you back and online, and thank you for everybody online for staying the course as well and actually participating. There's more to be done tomorrow. So on behalf of the team, and I'll give all the listed thanks tomorrow, but I mean, amazing. Thank you for the moment, and we will see you all bright and early tomorrow.
Thank you so much.